Breaking news for every single person who has been told their hip pain is a hip problem, it is not. And the proof is sitting in peer-reviewed medical journals that most doctors simply do not have time to read. Three specific structures in your body, none of them inside your hip joint, are responsible for the overwhelming majority of what Americans call hip pain. Three structures that no standard hip X-ray examines. Three structures that no routine hip MRI captures. And three structures that, when properly identified and properly treated, produce results so dramatic that patients who have suffered for years describe the experience as, "Why did nobody ever tell me this before? Today I am telling you, right now, everything, and your hip has been lying to you, not intentionally, not maliciously, but every single morning when you wake up and feel that pain, and your brain says it is your hip, your brain is wrong. Pain is not GPS. It does not always tell you where the problem is. It tells you where the signal ends up, and for hip pain specifically, the signal almost never ends up where it starts. The starting point is hidden, overlooked, completely different from where you feel the pain, and today, for the very first time, somebody is going to show you exactly where that starting point really is, and why finding it changes absolutely everything about your recovery. And real quick, before we go any further, if you know someone whose hip pain has never truly responded to treatment, someone who has had injections, physical therapy, maybe even surgery, and is still suffering, pause this video right now and send it to them immediately, because what we are about to share could be the answer they have been searching for all along. And if you are not subscribed yet, hit that subscribe button right now. Every single week, we bring you honest, research-backed, and genuinely life-changing health information that your doctor probably never had time to explain. Now let us get completely into this, because what you are about to learn is going to change everything about how you understand and approach your hip pain. Let us start with something that most people have never been told about pain. And once you understand this one concept, everything else in this video will make complete and perfect sense. The concept is called referred pain. Referred pain is the phenomenon where pain is felt in one part of the body while the actual source of that pain is located somewhere else entirely. This is not a rare or unusual occurrence. It is an extraordinarily common feature of human pain physiology that affects millions of people every single day. The reason referred pain happens is rooted in the way your nervous system is wired. Multiple structures in your body, muscles, joints, organs, nerves, share the same nerve pathways to your brain. When one of these structures sends a distress signal through a shared nerve pathway, your brain sometimes cannot accurately determine which structure the signal originated from, and it assigns the pain to the wrong location. The location where you feel the pain, not the location where the pain is actually coming from. Hip pain is one of the most dramatic and most clinically significant examples of referred pain in the entire human body. Study after study in orthopedic and pain medicine literature has confirmed that a significant percentage, some researchers estimate as high as 60 to 70%, of patients presenting with hip pain have pain that is primarily or significantly driven by sources outside the hip joint itself. These patients are examined, x-rayed, and treated for hip joint pathology, arthritis, labral tears, bursitis, and their pain never fully resolves because the actual source of the pain signal is somewhere else entirely and has never been addressed. This is the epidemic of misdiagnosed hip pain that is affecting millions of Americans right now, and the three hidden sources we are about to discuss are at the very center of it. The first hidden source of hip pain that most doctors completely miss is the sacroiliac joint, commonly called the SI joint. The sacroiliac joint is the joint that connects your sacrum, the triangular bone at the base of your spine, to your ilium, which is the large wing-shaped bone of your pelvis. You have two SI joints, one on each side, and they sit directly behind and slightly above your hip joint. The SI joint is one of the most pain-generating structures in the entire human body, and yet it is one of the most overlooked and underdiagnosed sources of hip region pain in clinical practice. The reason SI joint pain is so consistently confused with hip pain is the anatomy of its pain referral pattern. When the SI joint is inflamed, stressed, or dysfunctional, which happens for many reasons including leg length discrepancy, muscle imbalance, previous injury, pregnancy, and the natural joint laxity that occurs with aging, it refers pain in a very specific and very predictable pattern. That pattern includes the outer hip, the groin, the anterior thigh, and the buttock, which is precisely the area that most people and most doctors associate with hip pain. A landmark study published in the journal Spine found that SI joint dysfunction was the primary source of pain in approximately 15 to 25% of patients who presented with what appeared to be hip pain but had no significant hip joint pathology on imaging. These patients had perfectly normal hip joints on their X-rays and MRIs, but their pain was completely real and often severely debilitating. The telltale signs that your hip pain may actually be coming from your SI joint include pain that is worse when you roll over in bed, pain that flares when you stand up from a seated position, pain that is aggravated by standing on one leg, and pain that extends from the outer hip down toward the groin or inner thigh rather than being localized to the joint itself. A simple clinical test called the Faber test, where your leg is positioned in a specific way to stress the SI joint, can help identify whether your SI joint is contributing to your hip pain. Ask your doctor or physical therapist specifically about SI joint assessment if you have not had one, because standard hip evaluations almost never include it. The second hidden source of hip pain is the piriformis muscle, and this one is so commonly overlooked and so commonly the source of what people call hip pain that some researchers have given the condition its own name, piriformis syndrome. The piriformis is a small, deep muscle that runs from your sacrum, the same area as your SI joint, across through the deep gluteal region and attaches to the top of your femur, your thigh bone. It sits deep beneath the gluteus maximus, and its primary function is to rotate your hip externally and stabilize your hip joint during movement. The piriformis muscle is uniquely important for another reason. The sciatic nerve runs either directly beneath it or, in some people, directly through it. When the piriformis becomes tight, inflamed, or goes into spasm, which happens very commonly in people who sit for long periods, in runners, in people with leg length discrepancies, and in anyone with altered gait mechanics, it compresses the structures around it and refers pain in a pattern that is almost indistinguishable from hip joint pain, deep aching in the outer hip and buttock region, pain that radiates down the outer thigh, discomfort that worsens with sitting, walking, or climbing stairs. These are the classic symptoms of piriformis syndrome, and they are also the classic symptoms of hip joint pathology. The difference is critical, because hip joint treatments do absolutely nothing for piriformis syndrome, while specific piriformis-targeted stretching, manual therapy, and dry needling can produce dramatic relief in weeks or even days. Research published in the Journal of Orthopedic and Sports Physical Therapy found that piriformis syndrome was significantly underdiagnosed in patients presenting with hip pain, with many cases being misattributed to hip joint arthritis or bursitis for months or years before the correct diagnosis was made. The diagnostic test most useful for identifying piriformis involvement is the FAIR test, flexion, adduction, and internal rotation of the hip, which reproduces the deep buttock and hip pain when the piriformis is the source. Again, ask your healthcare provider specifically about piriformis assessment if hip pain evaluation has not included it, because in a significant percentage of cases, it is the piriformis, not the hip joint, that is causing every bit of your suffering. The third hidden source of hip pain, and perhaps the most surprising one on this list, is the lumbar facet joints of the lower lumbar region, specifically the L3, L4, and L4, L5 facet joints. Now, before you think this is just another discussion about the back, hear this out completely, because the referral pattern from these specific joints is not what most people expect. The lumbar facet joints are the small paired joints on the back of each vertebra that link your spinal bones together and guide the movement of your spine. When these joints become inflamed or arthritic, which is extraordinarily common in adults over 50 and accelerates with age, they refer pain in patterns that travel away from the spine and into the hip, groin, and thigh regions. The L3, L4 facet joint specifically refers pain to the outer hip and anterior thigh in a pattern that can be completely identical to hip joint pathology. Patients with L3, L4 facet joint pain often describe deep aching in the hip that is worse with prolonged standing, walking, and particularly with spinal extension, arching backward, because this movement compresses the facet joints and amplifies their pain signal. A study published in the journal Regional Anesthesia and Pain Medicine found that facet joint-mediated pain was the primary diagnosis in a substantial percentage of patients initially referred for hip replacement surgery who had failed to respond to conservative hip treatments. When these patients received diagnostic facet joint injections confirming facet joint involvement and subsequently underwent facet joint treatment, their hip pain resolved or significantly improved without any hip surgery at all. This finding, that some patients who are referred for hip replacement surgery actually have facet joint pain masquerading as hip pain, is one of the most important and most underappreciated findings in musculoskeletal pain medicine. And it underscores the critical importance of ensuring that facet joint referral patterns have been properly assessed and ruled out before anyone agrees to any invasive hip intervention. Now, I want to stop right here and share a story with you, because everything we have been discussing becomes so much more real and meaningful when you see it in someone's actual life. Victor is a 64-year-old retired marine biologist from San Diego, California. He had been dealing with severe right hip pain for approximately 2.5 years. The pain was deep, aching, and constant, located in his outer right hip and groin area, and it had progressively worsened to the point where walking more than 15 minutes, getting in and out of his car, and sleeping on his right side had all become genuinely impossible. He had seen his primary care physician, an orthopedic surgeon, and a sports medicine specialist. He had received 2 cortisone injections directly into his right hip joint, the first providing about 3 weeks of partial relief, the second providing almost none. His orthopedic surgeon had reviewed his hip MRI and found moderate joint space narrowing consistent with early to moderate osteoarthritis, and had begun discussing the possibility of hip replacement surgery as a future option. Victor was deeply reluctant to consider surgery. He was a scientist by training in nature. He wanted to understand the mechanism before he accepted the intervention. He began reading the medical literature on hip pain and referred pain patterns himself, something his scientific background gave him the tools to do. He came across multiple studies on SI joint and piriformis referred pain patterns and was struck by how precisely the descriptions matched his own symptom location and behavior. His pain was worse when rolling over in bed, an SI joint sign. It flared dramatically when he stood up from sitting on another SI joint sign, and he had a deep tenderness in his right piriformis region that he had never mentioned to any of his doctors because he had assumed it was just a tight muscle. He brought his research to a sports medicine physician who specialized in musculoskeletal pain diagnosis and asked specifically for SI joint and piriformis assessment. The assessment was revealing. Victor's SI joint provocation tests were strongly positive on the right side. His piriformis was severely tight and tender and reproduced his hip pain completely with the FAIR test. His hip joint itself, despite the imaging findings, showed only mild provocation on clinical testing. His new physician's assessment was that Victor's pain was primarily driven by SI joint dysfunction and piriformis syndrome, not by his hip joint arthritis, which, while present, was likely a minor contributor rather than the primary pain generator. Victor was started on a targeted treatment protocol: SI joint stabilization exercises, specific piriformis stretching and dry needling, and gait retraining to address a subtle leg length discrepancy that had been driving the SI joint stress for years. 6 weeks into this protocol, Victor called his wife from the beach near their home in San Diego. He had just walked 45 minutes along the shoreline, something he had not been able to do in over 2 years, without significant pain. He was emotional on the phone, not because the pain was completely gone. It was not yet. But because for the first time in 2.5 years, something was actually working. Not masking, not temporarily numbing, actually working. His right hip pain, the pain that 2.5 years of hip-focused treatment had failed to meaningfully improve, had reduced by what he estimated was 65% in 6 weeks of treating the actual source rather than the hip joint. Victor continued his protocol for another 4 months, and by the end of that period described his hip pain as approximately 85 to 90% resolved. The hip replacement surgery conversation was permanently shelved. He walks the San Diego shoreline every single morning now. He told his sports medicine physician, "You treated the source instead of the symptom." That made all the difference. So what do you do with this information? What are the practical, immediately actionable steps you can take right now to find out whether your hip pain is truly coming from your hip or from one of these 3 hidden sources? Here is exactly what to do. First, request a comprehensive musculoskeletal assessment from a sports medicine physician, a physical therapist specializing in hip and pelvic pain, or an orthopedic specialist with expertise in differential diagnosis. Specifically, request assessment of your sacroiliac joints using provocation tests, including the Faber, Fader, and compression tests, specifically request assessment of your piriformis muscle using the FAIR test and direct palpation, and specifically request evaluation of lumbar facet joint referral patterns using Kemp's test and Facet loading maneuvers. These are standard clinical tests that take minutes to perform and that can immediately reveal whether your pain is coming from your hip joint or from one of these three hidden sources. If you have had hip evaluations that did not include all of these assessments, you have not had a complete evaluation. Second, pay attention to the specific behavioral patterns of your pain. SI joint pain is typically worse with rolling in bed, transitioning from sitting to standing, and single leg activities. Piriformis pain is typically worse with prolonged sitting, crossing your legs, and activities that internally rotate the hip. Lumbar facet referral pain is typically worse with standing and extension movements and better with sitting and flexion. Hip joint pain is typically worse with weight bearing and internal rotation of the hip and is often associated with groin pain during walking. These behavioral distinctions are not perfect, but they can give you and your healthcare provider important clues about where to look. Third, if SI joint dysfunction is confirmed as a significant contributor, ask about a targeted SI joint stabilization program that includes specific exercises to strengthen the muscles that support and control SI joint movement, particularly the gluteus medius, multifidus, and transverse abdominis. A well-designed SI joint stabilization program has strong clinical evidence and can produce dramatic improvements in SI joint-mediated hip pain without any injections or invasive procedures. If piriformis syndrome is confirmed, ask about a combined program of piriformis stretching, dry needling, or trigger point therapy, and the activity modifications that reduce piriformis loading. And if lumbar facet referral is identified, ask about facet joint-specific manual therapy and exercise programs that address facet joint inflammation and movement dysfunction. The bottom line is this. Your hip pain deserves a complete and thorough investigation, not just a hip x-ray and a cortisone injection and a discussion about eventual surgery. The three hidden sources we have discussed today, the sacroiliac joint, the piriformis muscle, and the lumbar facet joints, are responsible for a significant percentage of what Americans call hip pain every single year. Victor's story is not unusual. It is representative of thousands of people across America whose hip pain is being misattributed and mistreated while the actual source goes completely unaddressed. You deserve better than that. Ask the right questions, request the right assessments, and make sure that before anyone treats your hip, they have definitively confirmed that your hip is actually where the problem is. Now, before you go, drop a comment below right now and tell me your age and the city you are watching from. And tell me, have you been treated for hip pain without lasting results? Do you think your pain might be coming from one of these hidden sources? I want to hear your story because your experience matters to everyone in this community who is going through the same thing. I read every single comment personally. And if this video gave you something genuinely valuable, a new direction, a new question to ask, a real reason to dig deeper into what is causing your pain, please share it right now with someone whose hip pain has never truly responded to treatment. Hit that subscribe button, turn on the notification bell, and I will see you in the next video. Find the real source, because treating the right place changes everything. This video is for educational and informational purposes only and does not constitute medical advice, diagnosis, or treatment of any kind. The information presented reflects publicly available research and clinical literature as of 2026. The patient story featuring Victor is for illustrative purposes only. Individual results will always vary. Hip pain has many potential causes, and a proper in-person evaluation by a qualified healthcare professional is always required for accurate diagnosis and treatment. Never use information from this video to self-diagnose or delay seeking appropriate medical care. Always consult with a board-certified physician, orthopedic specialist, or physical therapist before making any changes to your treatment plan. The creator of this channel is not a licensed medical professional. No statements in this video have been evaluated or approved by the FDA. Nothing in this video is intended to diagnose, treat, cure, or prevent any disease. Viewer discretion is advised.